So now it's time for one of the most awaited events of today's program, the SAARC Oration. So please rise for the ceremonial procession.
Please be seated. Professor Owen Parkes, Vice President of the Royal College of Surgeons of Edinburgh, distinguished past presidents, members of council, ladies and gentlemen, it is my great pleasure today to commence the second oration of the Golden Jubilee Sri Lanka Surgical Congress 2021. Today's orator is Professor S. Rajendra, who is Professor in Surgery at the University of Jaffna Medical College. He will be delivering his oration titled Renal Stone Analysis and Metabolic Evaluation in Patients with Nephrolithiasis. Do they add epidemiological data or aid to tailor preventive medical therapy? So now I invite Professor S. Sivaganesh to read his citation.
The President, Council of the College of Surgeons of Sri Lanka, the Royal College of Surgeons of Edinburgh, and the SAARC Surgical Society. It is my privilege to introduce the SAARC orator, Professor Sittambalam Rajendra. He is my colleague, my friend, and we learnt the ropes of surgery and trained together in the early 2000s. Dr. Rajendra was born in Kokuville, Jaffna. He had his primary education in Jaffna Hindu Primary and secondary education in Jaffna Hindu College and later in St. Patrick's College, Jaffna. He had his undergraduate education in the Faculty of Medicine, University of Jaffna, and he was successful at the final MBBS examination, passing with second-class upper honors with a distinction in obstetrics and gynecology. He received the Dr. William Paul Medal for the best performance in medicine and the Nandi Gold Medal for the overall best performance at all examinations in the university. He successfully completed the Master of Surgery and Diploma of the Member of the Royal College of Surgeons of England, MRCS, subsequently, and had his overseas training in Australia. He was board certified as a surgeon in general surgery in 2007 and joined the University of Jaffna as a senior lecturer in 2012. He has completed the diploma in laparoscopic surgery of the Strasbourg University in 2015 and received the fellowship by the college in 2016 and that of the Minimal Access Surgeons of India in 2017. He was a member of the Board of Study in Surgery, PGIM Colombo, and a trainer and examiner for postgraduate surgical examinations conducted by the Postgraduate Institute of Medicine. He has been appointed as a postgraduate surgical tutor for Teaching Hospital Jaffna and was also the president of the Northern Chapter of the College of Surgeons of Sri Lanka and a council member of this college from 2016 to 2018. He has held several academic and administrative posts in the Faculty of Medicine, Jaffna. He is a course director of the University of Jaffna International Centre of Royal College of Surgeons of England, Basic Surgical Skills Training course, and the core skills in laparoscopic surgery. He has made several presentations at national and international conferences, won the JMA Prize for the Best Research Paper at the Jaffna Medical Association sessions in 2012 and 2017, and has several publications in peer-reviewed journals. He was selected for the S.J. Stephen Gold Medal for the Best Published Article in the Sri Lanka Journal of Surgery last year. He is an author, and he's authored books on the history of Jaffna, or history of surgery rather in Jaffna, still not gone to history of Jaffna, and several other books for undergraduate and postgraduate students. He delivered the first memorial lecture for Dr. M. Ganesharatnam, former president of this college, by the Northern Chapter of the College of Surgeons of Sri Lanka, and has also delivered the Professor C. Sivanyanasundram Memorial Oration of the JMA. I can go on much more about Rajendra but alas, I have just 3 minutes. So ladies and gentlemen, let me introduce the SAARC orator for 2021, Professor Sithambalam Rajendra.
Professor Rajendra, now I invite you to come forward and receive the Oration Medal.
Thank you very much, Professor Sivaganesh, for that kind introduction. President, College of Surgeons of Sri Lanka, Honorable Council members, members from Royal College of Surgeons of Edinburgh, members of College of Surgeons of Sri Lanka, senior professors, consultants, my colleagues and friends, and those who joined the session via virtual platform. First of all, I would like to express my sincere thanks to the College of Surgeons of Sri Lanka and the Council of Surgical Congress 2021 for selecting my paper and thereby giving me an opportunity to present this SAARC Oration 2021. It's indeed a pleasure and an honor for me to be the first surgeon from Jaffna to deliver this prestigious SAARC Oration. The South Asian Association for Regional Cooperation, SAARC, was started in 1985. SAARC Surgical Care Society was established 10 years later in 1996. Ever since its establishment, it has been striving for evidence-based better surgical care in its regional countries. Keeping this core aim of improving surgical care and prevention of health conditions needing surgical intervention, I present my SAARC oration on renal stone analysis and metabolic evaluation in patients with nephrolithiasis. Do they just add to the epidemiological data, or do they also aid to tailor preventive medical therapy? The oration will focus on nephrolithiasis, renal stone etiopathogenesis, analysis of chemical composition of renal stones, metabolic evaluation in nephrolithiasis, preventive medical therapy, and recommendations. Nephrolithiasis. What is the current understanding? Renal stone disease has been in existence in the world for thousands of years because kidney stones have been demonstrated in a 7,000-year-old Egyptian mummy. It is a common clinical problem still in surgical practice worldwide. In the recent decades, we have gained better understanding about this condition, nephrolithiasis. How can we exploit this new understanding to better patient management? The prevalence of renal stones differs based on environment, climate, ethnicity, diet pattern, and heredity. The so-called stone belt exists across the world that is basically where the climate and social condition determines the prevalence of stone disease to be in the range of 10 to 15%. The prevalence of renal stone disease in Asia is reported to be 1 to 5%. The exact prevalence of renal stone disease in Sri Lanka is not known, but Rajendra et al. In 2015 reported the fact that there is no significant difference in the composition of renal stones between the 3 climatic zones in Sri Lanka. Further, the prevalence of stone composition can vary in the same region of a country over a period of time. Thind et al. In 1989 reported that the prevalence of calcium oxalate renal stone has increased from 26% to 82%, while the struvite stone has decreased from 20% to 5% in northwestern India over 3 decades. Socioeconomic and nutritional factors were attributed to this chronological variation of the renal stone prevalence in that particular region. Renal stones can be painful or silent. Usually, renal stones cause severe loin pain associated with nausea and vomiting. But renal stones can be incidentally identified on ultrasonography of abdomen in about 3% of asymptomatic patients in developing countries. These silent stones, patients with these silent stones are at risk of presenting with obstructive uropathy and renal impairment at the time of diagnosis. About 10 to 20% of stones need surgical removal. Technological advances have revolutionized the method of stone removal. The invasive methods such as pyelolithotomy and nephrolithotomy have been replaced in many instances by minimally invasive and non-invasive methods like extracorporeal shockwave lithotripsy, PCNL, and URS laser lithotripsy. These sophisticated surgical techniques are practiced in Sri Lanka for stone removal. middle-aged group population, the aging from 30 to 60 years, doing laborious work, are affected mostly by renal stones. So obviously, the renal stone disease imparts a significant physical burden to the patient and financial burden to the family and of course to the healthcare system. Renal stone etiopathogenesis. Nephrolithiasis is a pathological biomineralization process governed by pathoanatomical factors and physicochemical factors. The pathoanatomical factors are changes that are taking place in the kidney at the site of stone formation. Supersaturation of glomerular filtrate will lead to formation of crystals and subsequently renal stone formation. Randol plaques, the calcium phosphate deposition, can be a nidus for stone formation at the renal papilla. Similarly, plaques in the vasa recta and the subsequent calcification that can erode into the papillary interstitium can be the site of formation of calcium oxalate stones. So, analysis of chemical composition of renal stones can throw light to detect different types of stones and their kinetics of nephrolithiasis. The physicochemical factors are general factors modifying the pathological process taking place at kidney tissue. These risk factors can affect the homeostasis of the body, which can be detected by blood investigations. They can also affect the renal physiology and can have urinary manifestations, which can be detected by urine analysis. So metabolic evaluation of renal stone former can bring to light the predisposing risk factors for renal stone formation. This slide illustrates the known risk factors against the renal stone type. So when we do the analysis of composition of renal stone and metabolic evaluation, basically we try to identify the renal stone type and the possible predisposing risk factor. So a clearer understanding of the etiopathogenesis is a prerequisite for designing medical therapy. Why medical therapy? The epithelial injury by the nephrolithiasis induce upregulation of molecules which favor further crystal adhesions and stone formation. The residual nuclei of a previous stone can be the nidus of a new stone, that is, stones beget stones. Without preventive medical therapy, the risk of recurrent stone formation increases with time. Analysis of chemical composition of renal stones. What are the different chemical components of renal stones? And what are the different types of renal stones? As we have seen, because of differing etiology, renal stones are composed of mixtures of 2 or 3 chemical components. The commonly encountered chemical components are calcium oxalate, calcium phosphate, uric acid, triple phosphate, and cysteine. Now, the proportion of different chemical components is the key factor in identifying the type of renal stone. A classification system based on percentage composition of renal stone was described by Abdel Halim et al. In 1993 and is widely used to work out the type of renal stones. Why do we do an analysis of renal stone components? As we have seen, chemical composition of patient's stone is basically a biochemical biopsy of urinary environment at the type of crystal formation. European Association of Urology guidelines recommends analysis of urinary stone composition as an important investigation to initiate steps for prevention of recurrent renal stone formation. Apart from that, analysis of chemical composition of renal stones will also help for epidemiological trend assessment in the renal stone disease. Now, what are the methods of analysis of renal stones? Of course, there are several laboratory techniques available to assess the chemical composition of renal stones. Wet chemical analysis, infrared spectroscopy, X-ray diffraction crystallography are some of them. The infrared spectroscopy is a standard technique for chemical analysis of renal stones. This technique is specific, provides reliable quantitative analysis, and accurately characterizes the stone sample. I will give few seconds to go through this busy slide. This is the sample report of the stone analysis by infrared spectroscopy. You can see the percentage composition of renal stone type will be nicely described in this analysis. An institutional-based cross-sectional analytic study was performed on patients surgically treated for renal stone disease in Teaching Hospital Jaffna from 2016 to 2018. The aim of this study was to assess different chemical composition of renal stones in Jaffna by infrared spectroscopy and comparing the type of renal stones in Jaffna with regional and international data to find out any unique difference in the type of renal stone in the northern Sri Lanka. Renal stones were retrieved from about 104 patients. The mean age of these patients was 48.2 years. Male-female ratio was 2.8:1. This table illustrates the different chemical components which was analyzed by infrared spectroscopy in Jaffna, and you can see the component composition of stones and the number of patients. The renal stone types were identified using the classification system described by Abdel Halim et al. Comparison of renal stone types at national, regional, and international level reveal the fact that although different analytic methods were used to detect the type of stone, the commonest stone worldwide is the calcium oxalate type of renal stone. Regional variations in renal stone type and the impact of clinical management. These two questions were considered in this context. First question, is there a difference in prevalence of renal stone type between regions in Sri Lanka? Based on the available published data about the composition and type of renal stones in Sri Lanka, relatively more uric acid stones were found in Jaffna when compared to Colombo. The next question is there a variation over time in the prevalence of renal stone type in Jaffna? When the results of our study was compared with a similar study which was performed 30 years ago, it was found that there was increase in the prevalence of uric acid stones. There were 14 patients with uric acid stones in this study. 10 out of 14 patients who had uric acid stone were diabetic patients, which indicates the possible fact that the metabolic syndrome and diabetic mellitus are major risk factors for uric acid stone formation. When the two morphological forms of renal stones are concerned, namely the stagone and non-stagone, most of the stones in Jaffna were of non-stagone morphology. When we considered the renal stone type making up these morphological forms, calcium oxalate type of renal stone were the major type of renal stones for both forms of morphologies. Okay, the comparison of constituent of stagone renal stones at national, regional and international level was compared. Now this comparison showed a striking difference in the type of renal stone among the stagone calculi in the loco-regional and Western world. In the South Asian region, the component composition of stagone mostly is calcium oxalate, whereas in Western world, mostly it is truite. So the etiology of stagone calculi must be different in these regions, probably explaining the impact on the patient management with these renal stones, because the extent of renal tissue injury is more with truite stones. This article was published in the Sri Lanka Journal of Surgery with the title, "Is there a unique difference in the type of renal stones in northern Sri Lanka? Analysis of chemical composition of renal stone in Jaffna by infrared spectroscopy." Metabolic evaluation in nephrolithiasis. Why do we do metabolic evaluation in nephrolithiasis? As we have seen, metabolic factors are involved in renal stone pathogenesis. Some factors encourage and some factors discourage stone formation. Recurrent stone formers tend to have at least one metabolic abnormality. Usually they have multiple metabolic abnormalities. What are the parameters tested in metabolic evaluation? There are lithogenic risk factors which promote the renal stone formation. Elevated levels of these factors will favor renal stone formation. Their higher levels can be detected by metabolic evaluation. Similarly, there are factors which inhibit the stone formation. Lower than normal levels of these factors will have influence on the renal stone formation, and their lower levels can be detected in the metabolic evaluation. Who will undergo this metabolic evaluation? In-depth metabolic evaluation can be considered in any patient with nephrolithiasis who is prepared for blood investigations and 24-hour urine analysis, and who is also willing for alteration in diet or commence medical treatment. So obviously, metabolic evaluation requires immense patient motivation, compliance, and time. Apart from that, this requires additional laboratory funds and also puts pressure on the health service due to multiple patient visits. Considering these, extensive metabolic evaluation has been recommended for recurrent stone formers, defined as having 2 or more episodes of kidney stones, and also patients with multiple or bilateral stones. A cross-sectional analytic study on metabolic evaluation in patients with recurrent, multiple and bilateral stones was carried out in Teaching Hospital Jaffna from 2016 to 18. From each patient, a fasting blood sample was obtained to estimate the serum ionized calcium, creatinine and uric acid. A 24-hour urine sample was obtained once to estimate phosphorus, creatinine, oxalate, uric acid, magnesium and calcium, and once again to estimate citrate. Results were analyzed using SPSS version 12.21 for Windows, and the descriptive statistics was computed for all biochemical variables and for each of the diagnostic categories. The mean age of this case series of patients with recurrent, multiple and bilateral renal stones was 47.1 years. There were 20 males and 10 females. Of the 30 patients, 24 had bilateral or multiple stones and 6 patients had recurrent stones. A low 24-hour urine volume, that is less than 1,500 milliliters, was found in 12 patients. When these 30 patients were considered as a single study group, the mean values of metabolic parameters assessed in urine was found within reference range. A similar finding was there for the parameters we assessed in blood as well. But when we assessed these patients individually, out of 30 patients, 24 patients had either isolated metabolic abnormality or combined metabolic abnormality. This indicates the fact that there is no single metabolic test that is standing out as a single metabolic abnormality for the group of patients with recurrent, bilateral or multiple renal stones. Is there a major difference in the prevalence of metabolic abnormalities or renal stone formers in different countries? Comparison of metabolic abnormalities in patients with recurrent, multiple and bilateral renal stones at regional as well as international level revealed an interesting finding that those patients from South Asian countries tend to have multiple metabolic abnormalities when compared to the Western world. So the outcome of metabolic evaluation in this defined group of patients is likely to be beneficial in South Asian countries. This article was published with the title of Metabolic Evaluation of Patients with Recurrent Multiple or Bilateral Renal Stones in Jaffna in the Ceylon Medical Journal. Preventive medical therapy. There are recommended preventive medical therapy for specific metabolic abnormality. Preventive therapy is decided based on specific metabolic abnormalities identified by stone type and metabolic evaluation. It involves a lifestyle modification and pharmacological intervention. So before commencing the preventive therapy, it is very important to make sure the patient will comply with lifelong therapy. 6 to 8 weeks after initiating such treatment, the response to treatment will have to be assessed, possibly in a 24-hour urine analysis. During the follow-up period, the therapy can be tailored to individual patients. The recommended medical therapy for specific metabolic abnormalities have been illustrated in this table. Different dietary advice and medical treatment have been advocated for metabolic abnormalities concerned. Is there any evidence for effectiveness of preventive medical therapy on renal stone recurrence? Increasing the urine volume to 2 liters per day has reduced the renal stone recurrence by 40 to 50%. Low sodium, low animal protein, and moderate calcium diet has shown to reduce the stone recurrence. Reduction in dietary oxalate intake has an impact on reduction of calcium oxalate stone formation in patients with hyperoxaluria. Citrus fruits such as lemon and limes have some beneficial effect in reducing renal stone formation. Potassium citrate has shown to reduce calcium oxalate stones. Thiazide diuretics can reduce the recurrence rate of calcium oxalate stones. Urinary alkalinization has shown to reduce the recurrent uric acid stone formation. The recommendations. There is a need for nationwide large population study to confirm the prevalence of renal stone type, and in particular to assess the prevalence of metabolic abnormalities in patients with recurrent bilateral and multiple renal stones. And also it is needed to compare epidemiological data. The treating clinician in this field will have knowledge about effectiveness of medical treatment to prevent recurrent renal stone formation. They also know the attitude of patients to comply with lifelong treatment with periodic metabolic assessment. Gathering their knowledge and experience will help to implement treatment plans. A debate among specialists from SAARC countries dealing with this defined group of patients with recurrent multiple and bilateral renal stones could be initiated with the view of drawing a clinical management guidelines with special consideration in assessing the cost effectiveness and also benefit of full metabolic workout to these patients. These are the references made for the SAARC Oration 2021. Once again, I thank the College of Surgeons and the Surgical Congress 2021 for giving me this honor to deliver this SAARC Oration. Thank you very much.
Thank you, Professor Rajendra, for delivering the SAARC oration. That brings us to an end to the ceremonial proceedings of this event. Please remain standing in the usual manner until the procession leaves the hall. Thank you very much.